Good evening.
Good evening.
That was rubbish. Particularly at the back. You were particularly rubbish. You guys at the front, you were not bad. Good evening.
Good evening.
Excellent. Fantastic. So we've got a really exciting hour and a half with you this evening. We're going to have 4 speakers share with you a little bit about where we are now and what we're going to be doing and some of the big questions around data. So are you in the right place, do you think? Yes? Maybe. Okay, you'll just reserve judgment until you've heard them. Okay, refunds are at the back door right up there. It's locked. Okay, so what we're going to do is we're going to hear from our 4 speakers, and then we're going to have a series of questions. Okay, I've already got a few questions in advance. Thank you very much for those. But we want to make this as interactive as possible. Okay, you up for that? Yes. Catherine, are you up for that? I see you up there. Excellent. Good. So how many of you have been to this place before, the National Museum of Scotland? Oh, crikey, everybody apart from me. Okay. Thank you very much. Isn't that a wonderful place? Absolutely. There you go. It's that good. It's that good that it's falling to pieces. Maybe I'll just hold on. I'll hold on to this. Okay. So is this enough advertising for you?
Yeah.
Okay. So isn't it an amazing place? Have you seen the piece? Have you seen the piece around the telegraph, the invention of the telegraph? So ballpark, in 1855, the first telegraph was a telegraph system was kind of developed over Scotland, and then they did a transatlantic one within 15 years, and then they did a trans-Pacific telegraph, I'm going to put this down, trans-Pacific within another 20 years. Quite amazing. Does anybody know how the telephone works? Does anyone ever wonder how? Does anyone know how the telephone works? Oh, so you know the answer?
As I said, I understand how a telephone works as long as you don't ask.
Okay. I won't ask you, but it's not just to do with how tight you hold it, right? So it's not like 2 cans and a bit of string. So my point is, there's lots of amazing developments that have happened in the last, century and a half. But right now, there's an amazing evolution of technology and connectedness across the world, isn't there? I mean, has there ever been a faster pace of technology and development? And we're going to hear tonight from some of our panelists, both some of the advantages in that, but also some of the huge threats and considerations that we have to have. So, without further ado, I'm going to introduce our first speaker. So we've got, as I say, 4 speakers. They're all going to speak for about 10 minutes or less. And then I'm going to open this hatch and I'm going to fall down if you talk more than 10 minutes. And then we're going to get into conversation. So our first speaker is Dr. Catherine Calderwood, who's the Chief Medical Officer for Scotland. And Catherine has led nothing short of a revolution in terms of how doctors engage with people in our care since she became Chief Medical Officer some 3 years ago? Yep. 3 years ago. So we're going to hear a little bit more about what Catherine calls realistic medicine. A big welcome for Catherine.
Thank you, everyone. I won't do the good evening because Brian's already done it and added a little joke, as he always does. And I'm now looking for my clicker, which one of the other speakers must have stolen. Mr. Welsh, typical. So chief medical officers, you wonder what they do. I also am still wondering 3 years later. But you'll see that I'm originally an obstetrician gynecologist, and I still have an antenatal clinic on a Friday in the Royal Infirmary in Edinburgh, where I have done some of my training and my practice, and I'm the only chief medical officer ever, since chief medical officers were invented in 1874, who still sees patients. And I'm very proud of that, and so I'm telling you about that. I'm also the first female chief medical officer in Scotland. And the youngest. And I'll stop there. So my children were fascinated when I got this new job because they understood that when Mummy went to work, she was helping the ladies who were having their babies. And my son George and I were walking into school one morning, and he said, he's quite an earnest, small boy, age 10, quite rules, likes his rules. Mum, this new job of yours, all about keeping people healthy. I went, yes, it is, that's very good, George. He said, you're not going to ban sweets, are you? And actually, he might have a point. But anyway, I said, no, George, I'm not going to ban sweets, and I'm unlikely to ban wine either, but I would prefer if you didn't tweet that. So I was asked to talk a little bit about realistic medicine, and I thought it's difficult knowing an audience how much you will know of the report, which was my first annual report in 2016, and I decided to do something different. Chief medical officers write a report, all 4 chief medical officers in the UK do, and it's usually about the health of the nation or some particular topic that's affecting health. But I decided to write to the doctors of Scotland because I was hearing from them that they were not happy about the way that they were practicing medicine. They didn't feel that they were practicing medicine in the same way as they had done when they had left medical school as bright young things who wanted to help the people in front of them. They become very disease-focused. And about the same time, I read some research which says that if a physician or a doctor is given a terminal diagnosis, they actually make quite different decisions for themselves than they might do for the patients. So if we ask a group of physicians and doctors what they would do at the end of life, 88% of doctors would not have hemodialysis, 95% of doctors would not agree to have cardiopulmonary resuscitation, and 67% of doctors would not agree to be admitted to intensive care. So I wondered what it was about us with the knowledge that made us make different choices or recommend different choices for ourselves and our families than the way that we were actually practicing. And that has become quite a theme within my realistic medicine report, is what is actually the person's priority? Do they have all the information they need? Have they had decision-making that has been shared between them and the person looking after them? And it's spread far, far beyond doctors. It's nurses, physiotherapists, midwives, paramedics have all written to me to say we think that this should be how we're practicing healthcare in everything that all of us are doing. So we wanted to talk about a personalised approach to care and something that actually is focused on what the priorities for that person would be. So I have a friend and colleague called Graham Ellis. He works in Lanarkshire, and he's in charge of the hospital at home service there. Now, Graham is a care of the elderly physician in the hospital, but what he does is provides care at home for people with ward rounds that are done on Skype on an iPad. The physiotherapist can go out to the home, but that person stays at home where they traditionally would have been admitted. And Graham got a call one evening. It was a very well-known patient who was very breathless. This man was well-known because he was in and out of hospital being admitted and readmitted many times in a year. This man had an interesting condition because he had a very interesting hobby. So this man was a pigeon fancier, and he had pigeon fancier's lung. That's caused by the dust in the pigeon's feathers. It's a progressive disease. People get more and more breathless and more restricted in what they can do over time. It doesn't go away, it tends to get worse. This man came every admission and every outpatient review appointment, and when he went, the person looking after him said, you do realise your lungs are going to get worse. You need to give up the pigeons. Your pigeons are causing this disease, the disease is going to get worse, you need to give up the pigeons and your lungs will stop deteriorating. So the man continued to be admitted. So Graham got this call and he thought, I wonder if he would be suitable for hospital at home. Perhaps he won't need to come in. I'll go to see him at home. So Graham went out to the man's house and his daughter was there. Graham examined him and thought, really not great. Going to have to bring him in, I think, probably. He started to say, you do realise that this is all the pigeons, don't you? Your lungs are going to I'm going to have to keep coming and people are going to see you and admit you to hospital and your lungs are going to get worse unless you give up the pigeons. And he could see the woman's daughter beckoning to him from the side of the room. And she said to him, Dr. Ellis, no one from the hospital has ever been to my father's home before. I wonder if you would like to see his back room. So she took Graham to the back room, which is absolutely stuffed full. And those are portraits of his winning pigeons, not photographs. Because this man, from a small bit of Lanarkshire was once the UK champion pigeon racer. And she pointed at these unassuming-looking sheds and she said, Dr. Ellis, there are 200 to 300 pigeons in those sheds. My father spends hours with them every day. He feeds them, he cleans them, he talks to them. My father loves his pigeons, and he would rather die than give up his pigeons. It doesn't matter how many people tell him that the best thing to do would be to give up his pigeons. He isn't going to. And Graham went back into the sitting room. He hooked up some antibiotics to the standard lamp. He gave the man an injection of steroid and allowed him to stay at home with his pigeons. And that is an example of realistic medicine. And so the response to this concept, I suppose, of really finding out what medicine people want and actually what their priority in life is what realistic medicine is all about. And as I've alluded to, and as Brian said, we've now had responses from all around the world. I think we stopped counting the Twitter stuff because we're at 25 million people across the world having seen this report. We've given up counting. But I know, sitting here because I've been asked to come and talk about data. So some of this is about involving the public. I seem to already have the healthcare professionals on my side, but what I really want is that we can ask people what they want from realistic medicine. Realistic medicine might mean something to me, but it's no good if it doesn't mean something to the pigeon fans here. So we have asked this population of Scotland, we've done a survey, we've collected data, we have asked people what they would like from their medical care. And if I had longer, I would describe that. But essentially, one of the key points that came out to me was we asked people what they thought was a good doctor. And 71% of the people asked said that they thought a good doctor should be knowledgeable and competent and that they should have a medical degree. I thought that the GMC would be quite pleased about that. And the 29% of people that, anyway. So, but the next most common answer as to what their priority was from a good doctor was that the doctor was a good listener. Nobody said, I want more treatment, I want expensive this. They wanted to be listened to. So again, what I'm starting in this revolution, Brian calls it, I don't know what we call it, a movement, is to get these data from people, to find out actually what is the right thing. And one size does not fit all, because for somebody, everything might be appropriate. Doing everything, being admitted to hospital, having the drugs, having the treatment. But for other people, it won't be because their priorities are different. Realistic medicine is also, though, about using data to change our healthcare and to improve it. And again, if I had longer time, I would give you many, many examples of where the collection of people's data has really influenced how me and government and my colleagues have changed the way we work. But my current, this slide landed on my desk this week, and I thought this is perfect for this audience. So I'll talk you through it. We started around 8 years ago a vaccination program against human papillomavirus. Now, those of you who know anything about that know that that's a risk factor for cervical cancer. The vaccination, much like many vaccinations that we've worked on over the years, prevents the replication of the virus and the destructive nature of that. In this case, kill human papillomavirus and, make people immune to that, and then they will not have human papillomavirus and the cells that leads then to a risk of cervical cancer. Now, if I tell you that a lot of our diseases across Scotland have a deprivation gradient, they are worse in people from poorer backgrounds, worse for a lot of reasons. People present later, they're therefore at a later stage of the disease, they have other comorbidities, they're smokers, they have other issues that mean that their outcomes are much less good for some diseases in the poorer communities and better in wealthier communities. And cervical cancer is no different. So women present later with more advanced disease, do less well, but they also have a higher rate of cervical cancer in our poorer communities. So if you look at the blue dots here, the most deprived people are SIMD 1, the least deprived, the wealthiest people are number 5, and in people who have been unvaccinated, so before the programme, we had a rate of 15 cases of this precancerous change in women per 1,000 of the population. You'll see that gradient then in blue goes all the way down to the wealthier women who are not so, it's not so prevalent, around almost, it's about a third of the rate. But look at that vaccinated cohort. It's absolutely stunning, this slide. It is absolute, I cannot tell you how important this slide is. So firstly, because the rate of cervical precancerous cells has dropped, as you can see right across, and has dropped to about 4 per 1,000. So a very significant drop for those women whose rate was much higher. But uniquely, I think, in diseases I would talk about, it has completely flattened the inequalities gradient. So that thought that women from poorer backgrounds got cervical cancer more than other groups is not actually true if we remove human papillomavirus. And so what does this tell me? Well, for a start, it tells me that all those campaigns to have people having cervical smears, which led to the blue line, weren't going to the right people, were they? Because what we'd managed to do was get the wealthy people involved, and the others were not. So what we've done is we've given a full access to all, because schoolgirls are all offered the vaccine. There are loads of catch-ups if you've missed it. If you don't attend, we keep coming after you. We are vaccinating 90% of our young girls across Scotland at the moment, and look at the result in less than 10 years. It has taught me so many lessons. Those simple dots on a graph are absolutely fantastic because they will change the way that we prioritize our healthcare. They also change our attitude to what's perhaps been accepted as this is something we can do nothing about. The rate of cervical cancer or precancerous cells is this slide, but leading to cancer that's the way it is in those communities, and we can't change it, but we actually can. So you will hear more about this slide. As it happens, I'm an obstetrician gynecologist, so you might think I might choose something in women's health, but I think that we need to take those powerful, powerful data. And this is nothing short of I'm not going to say a miracle, but it really is close to something that we didn't ever believe would happen. And we will see the rate of cervical cancer, which is a terrible disease. We will see it reduced to virtually nothing, because it doesn't matter that you don't come for your smear tests anymore, because we vaccinated you at school. So I leave you with my other favourite realistic medicine story. We get to visit lots of people when we're out and about. And I met a man who was from Ayrshire. He'd had a knee replacement, and he was coming to see me as a person that had had some health care. And I walked in, how's the knee? It's not great, doctor. I said, oh, that's disappointing. Is it sore? Oh, it's just not great. Okay, well, can you walk? Yeah, but you're not pleased with your new knee? Not really. I said, why would that be? Is there a problem? He said, the thing is, doctor, my knees are sore. I like to talk to my neighbour standing on my doorstep. And so I asked them for a grab rail, and they gave me a bloody knee replacement. And I still can't stand, because I still don't have the grab rail. And so what had happened to this man, who no doubt had sore knees, had an x-ray, was seen to have, I don't think that a surgeon did an operation because the man didn't have something wrong with his knees, but that wasn't actually what the man wanted. So I leave, oh, hello, I've gone on too long. So I leave you with the realistic medicine of investigating what actually people, not patients, want from their care. Thank you very much.
Thank you very much.
Thank you very much, Brian. So I run the Data Lab, which is an innovation centre focused on helping organisations in Scotland, both commercial and public sector, use data and data science and artificial intelligence for benefit, whether it's a commercial benefit, society benefit, health benefit, and to help create new jobs and new opportunities. And working in data, it's, we'll just address the elephant in the room, will we? And Mr. Zuckerberg and giving his evidence at the Senate today. To be honest, my family and friends have never really taken an interest in what I do. Or she works in computers and can you fix my printer? Was pretty much as engaged as they used to get. And most of the time the answer was absolutely not, I have no idea. But they seemed really interested in this data thing. And everyone, so what about Facebook then? What have they been up to? So it's been really timely the last couple of weeks. And clearly there has been some, as they said on the radio yesterday, there's a bit of a stushy going on about all this use of data. But the crux of it was unauthorised use of data. We all use, or many of us use Facebook, not we all, many of us use Facebook. It is a free platform. You put your data in there, and their business model is that they will use your data to advertise to you. It's an advertising platform, but we don't pay for access to the service. Now, the crux of the problem was that data that you didn't give authority to be used and harvested, as it were, which sounds like organ harvesting, but they were harvesting data that your friends potentially had given them authority to harvest, and then use that to target you for marketing, to analyse your profile, and to build models. So there is clearly some bad actors in that space about what they were up to. But I would like to, I'm a bit of an optimist, and I do think that there is some absolutely amazing, valid, ethical and moral uses of data, and many of them going on right here in Scotland. And I'm going to share a few of those stories with you. And the first one is one of my real favourites. It's with a housing association in the Highlands called Alban Housing. And they have a large cohort of social housing, and they had a plan to build a group of fit homes, they called them. And they were working with a really innovative, dynamic off-site build manufacturing company called Carbon Dynamics. They worked with the NHS Highland and with some of the innovation centres, of which we're part of, to say, well, if we're going to build these fit homes, what should they look like? What should they have in them? They worked with their tenants to say, how comfortable are you with the types of technology that we could install in the house? And there's a big no-no to cameras, clearly. They don't want cameras. But equally, they were comfortable, their tenants were comfortable with sensors installed around the house, monitoring how they live, how they use the facilities in the house, and they were happy for that data to be used to help predict things that might happen to them. So the project that we're slightly involved in is the sensors around the home, and they are pumping out data about behaviours. And can you build algorithms that will predict when a tenant has an increased probability of falling over, and therefore stop the fall before it happens, so you don't have the knee replacements and the hip replacements? And the NHS have been working to say, well, actually dehydration, if you're dehydrated, your probability of falling increases. So what about sensors on the tap, and the kettle, and the toilet, and algorithms that are robust enough to say there's a problem here, this person is not drinking enough, they're not going to the toilet, they need some kind of intervention. And we try and stop the fall before it happens, and you don't need the big red button and the consequences of those falls in your health. So a really fascinating use of data with the full approval and comfort of the tenants of the housing association. And it's really interesting to see how that will develop. And in the future, there's technology being developed, for example, in sensors in the carpets and the flooring, to look at gait analysis. There's technology like Amazon Alexa that can analyse tone and speech. So my dad has Parkinson's. Wouldn't it be great if his Parkinson's nurse could automatically be told from Amazon Alexa, because she chats to my dad daily, to see how his speech is declining? Or sensors in the carpet that's monitoring his gait and analysing his gait to see that his walking is getting worse. Those are the kinds of things that are going to be available if we capture the right data and use the right algorithms on that data. So another great project that we've been involved in is with the Beatson's Cancer Hospital and advances in computer vision analysis and technology and MRI scans. And can you support the oncologist with more information and better help to delineate tumours from healthy tissue in complex neck cancers? And many of these technologies are used in different industries. So the same team that are working on that Beatson's project at Strathclyde University are working with a subsea pipeline inspection company that fly ROVs over subsea pipelines and cables. It's murky down there, it's difficult to see what's happening. So some of that same computer vision technology used in two very, very different disciplines. And I think that's one of the things that's great about Scotland being the size that we are. We can make those connections and join the dots between different industries and different domains and use the fantastic research capability and academic capability that we have. And one of the very small projects that we didn't take a lot of time, but it was the first time a different group of data sets had been brought together at the NSS and NHS. And we posed the question that said, could you predict which patients are likely to bed block or become delayed discharge? And I'm sure we all have personal stories about elderly relatives or friends that have gone into hospital, and once they have been clinically treated and are able to be discharged, they can't because the care package isn't set up, their grab rail hasn't been fitted, or their shower hasn't been converted. But those processes don't start till almost the patient's about to be released. So could we build algorithms using data that you know about the patient at point of entry into the acute care system to predict which ones are likely to bed block? And then you're doing something about it while they're still going through clinical care. And we built an algorithm and it's 97% accurate. And the teams are now testing that algorithm on data sets from other health boards, and it's looking good. It's holding firm at those kind of accuracy rates. So the use of data and using it in clever ways can absolutely change people's lives. So that's why I'm an optimist. And it's been great working with many partners, the NHS, IHDP, a couple of the other innovation centres on the Cancer Challenge. And there's a little bit about it in your booklet. And it's funded by Scottish Funding Council. And the test was, can we use data in new ways to improve cancer treatment pathways, to improve the patient experience as they're going through that treatment? And we've now worked with over 8 organisations across 2 different parts of that challenge. The first one is looking at new ways to collect information from the patient and integrate that with the clinical data. How are they feeling? How is the treatment working for them? What is their support structure like? So how do you capture that patient experience and patient outcomes to help inform future treatment pathways, both for them individually and then for cohorts of cancer patients? And the second one is much more technical around the use of data science and machine learning and other technologies to improve cancer treatment pathways. And we're really excited about the potential outcomes of those, and certainly 2 of the organisations are now running pilots in NHS Lothian and NHS Ayrshire and Arran around the patient-reported outcome and experience measures. So when you start to hear stories like this, I think it's hard not to be an optimist. I think we can use data in ways with the right morals and the right ethics to do real good. And it's going to be exciting to explore some of that with you later on in the conversation. Thank you very much.
For that. Now, our next speaker is Sarah Cunningham-Burley, who is a professor here in Edinburgh, a professor of medical and family sociology, but also a researcher in patienthood. So I look forward to hearing a bit more about what we're doing around data and genomics and how we're involving patients in sociology.
Okay, Thanks very much, Brian. And thanks to everyone for coming. I'm going to sit down as well. Sorry, I've also got a cough, so I hope my voice lasts out, but that might curtail what I have to say as well a little bit. So I am at the University of Edinburgh, and I have a strong interest in public involvement and public engagement in health-related issues and how they actually affect people and their lives. And I'm involved in two major programs of work at the moment that relate to this. So one is a program of work funded by the Medical Research Council in the FAR Institute, which is developing kind of socially acceptable and ethically robust ways to deal with data and linked data in a way that can then support research that will ultimately be for public benefit. And then the other, as Brian mentioned, is work that's looking specifically at how the incredibly fast-paced developments in data science, and particularly involving genetic and genomic data, themselves impact on the healthcare system and therefore what's available to patients, and how patients themselves work with, come to terms with, have to handle actually incredibly complex, increasingly complex information as they themselves make decisions about what's best for them in terms of treatment, particularly in relation to cancer, but it's also relevant to many, many other diseases. So a little bit about myself. And I also want to thank Steph for putting this event together from the Innovation Cancer Challenge, and look forward to all your questions afterwards. So while the others have been talking, I've also been rather admiring this, and it actually made me think we can use this example to think about data. So this is kind of like the data soup, isn't it? And it's getting bigger and bigger. There's masses and masses of data that we are all producing all of the time, and we've heard about some of those ways, both from Catherine and from Gillian. And we're doing it kind of knowingly, but actually we're probably also doing this unknowingly, not just through Facebook and unauthorized use, but lots and lots of our contacts with healthcare, with various other agencies are generating information that can be used as data. And then the kind of real challenge, I think, as Gillian suggested, is, well, then how do you begin to make sense of it? So how do you link it? How do we link patient-reported data with other environmental data and other things? And then out of all of that, do we get anything useful? I thought these were kind of a bit like algorithms. So this is what we want, something here that somebody can use, maybe in a clinic, that will help doctors and patients make a decision about best treatment or something else. But there's not many algorithms, are there yet? So there's masses and masses of data. And I think all along the way, there are a whole range of social, ethical, and actually deeply human issues that are in here, even though this is data, and certainly in here as we learn to deal with some of the results of the incredibly complex modelling that many of my colleagues do. So I wanted to talk today a little bit then at what I think some of those wider social and ethical challenges are, and talk about that at different levels. Clearly we are in an era where data-driven innovation is a major driver. It's a major driver for funders. It's part of the UK's industrial strategy, and it will have and is having a massive impact on the development and delivery of health and social care. So it's in medicine, but also across a range of other ways. And that wonderful hashtag that's been put away now, data saves lives, is one way of stressing the importance of data. But as I said, that's all information from you and me about our health, about our environment, and about our health care. So data probably can save lives, but it also does lots and lots of other things as well. And some of these things might be to add further complexity to already very, very difficult decisions that we as a society have to make, that the NHS has to make in terms of resource allocation, and that doctors, other healthcare professionals, patients, their families have to make about the care they provide, receive or share. And also what we have to do then as a society and as individuals to promote health and prevent illness. And we've heard some good examples of how interventions at societal level can really have an impact on individuals' health and the stubborn inequalities that we know persist in terms of our health care. So realistic medicine and the role of data within it aims to provide, amongst other things, I think Catherine has described as kind of personalised care and keeping the person, the patient, at the centre of shared decision making. and whether that person is a patient, an actual patient, a kind of patient in waiting, because I think we are all patients in waiting to some extent. We're all likely to get sick at some point. Or the kind of what we have talked about in our research, and one of my colleagues, Emily, is here, the kind of long-term consequences that might occur with disease. So being a kind of post-patient, some people might describe that as a survivor, someone living with a chronic condition. This kind of era of medicine has been described by Leroy Hood, who's president of the Institute of Systems Biology, as P4 medicine. So that's medicine that can be increasingly predictive. So we might be able to say who is at highest risk of disease, what can we do about it. That it's increasingly preventive. Maybe we can intervene so early that disease doesn't happen, or prevent accidents, as we've just heard. That it's personalised, so increasingly what I might get for treatment might be different from someone else, because the understanding of disease becomes ever more sophisticated, and then the treatments can be tailored accordingly. But also participatory. As I said at the beginning, these data come from all of us. So we actually participate actively or passively in this whole data-driven enterprise here. And so maybe what we need to do is become much more aware of that participation, make it more active than passive. And I'll talk a little bit about how I think we might do that. So we do need to think about that participation. So what kinds of issues does this data-driven world of health promotion and disease mean for us at different levels? And I'm going to just talk very briefly about 3 different ways in which we might come to ask questions about this, perhaps. So first of all, at a societal level, then at a kind of what it means for the healthcare system, the NHS in our case, and doctors and other healthcare providers, and then what it means for us as people and as patients. So at a societal level, we know that health and disease is a social issue as much as it is a medical or biological issues. And so the solutions that data-driven innovation pose are also social in their generation and in their effects and implications as well. So we have, and I think Catherine suggested this in her talk, always have to think about the kind of human and social side of the technological developments that we have in healthcare. So personalised healthcare, I think we'll all agree, is a really wonderful aim. But it mustn't produce a highly individualised approach to tackling disease and disease risk. Certainly individuals can do much to mitigate their own risks if they have sufficient resources with which to do that, if they happen to live in the right area and belong to the right social class. And there are many risks that can be ameliorated at societal level, and we've had a couple of examples of when that will happen. And we can do that through legislation, health promoting interventions, etc. But we do also know, despite the outstanding example that Catherine gave us, that we continue to experience wide gaps in the health, in disease experience and in the health experience within the Scottish population, UK population, as well as globally. So we do need to do a lot more. So we need to harness data to generate interventions that really do make a difference. So data science and epidemiology then can tell us a lot about these risks and help us to both develop and evaluate interventions that may minimise them. There's another level that we need to think about this a little bit from a societal perspective, and that is, as Gillian raised, what about the wider kind of ethical and social issues that pertain to the soup of data and what we might do with that. And so we need to develop a socially acceptable and ethically robust approach to data generation and data use in healthcare and in social care, for analytical purposes, for research purposes, and for healthcare delivery purposes. And the ways in which we might do that are to think about how to absolutely support transparency, and this is a good, this event is one example of that. And also to have debate about what constitutes public benefit, what kind of conditions as a society do we think we have to have in place before we can drive that public benefit in terms of data-driven healthcare. The research that myself and colleagues have done in this area, which has investigated and explored and deliberated with a whole range of people across Scotland, suggests that there is an urgent need for greater transparency, that people want a very clear sense that even though we're working in a situation where there is authorised and a good governance framework for linking data, particularly in the Scottish context, that people want to know a bit more about what's happening and have some sense of control over what happens with data that comes from them at some level. So I think we can do a lot more in terms of constant engagement around these issues. Now, if we think about the healthcare system, the NHS and doctors and kind of doctor healthcare providers' relationship with people and their patients, a learning healthcare system uses data constantly and in real time to support patient care. So this, in a sense, generates new forms of relationships. So when you're a patient, you are also a provider of data. And so that dual role has to be something that I think we both understand and respect as we deal with those kinds of interactions in a healthcare system or in a social care system. And healthcare professionals will become increasingly reliant on tools such as our lovely flowering algorithms, but won't have had necessarily very much involvement and may not have the best understanding of everything that has gone into the back scene here that has created those. I couldn't understand this. The mathematical modelers are in a world that is beyond my comprehension. So how do we close the gap between those levels of understanding within the range of expertise that we have within medicine? And then the next question is then how do we close that gap when doctors and others are trying to discuss these with patients as well? So the results of the flowers are not going to be simply represented. They are going to raise complex issues around making decisions about healthcare. So we need to think, I think, of issues around training, education, how to visualize and put across information, but also think about what different forms of responsibilities and accountabilities you have in terms of developing information and information tools when so many different people and so much different types of data have been brought to bear on that. So just lastly, before I finish, I wanted to say a little bit then about what does this mean for us as people or as patients or as patients to be. If we're thinking of data-driven innovation as really helping to predict who is going to become ill or who is going to need other forms of care, then we need to ask questions about what types of information do we want to know and what types of interventions that might come from that would be socially acceptable. We can't take all of that for granted, I don't think. So prediction can make patients of us all, and is that something that as a society or as individuals we might want? And prevention too, very important, but at what point do you intervene at a very, very early stage or at a pre-disease stage, and what does that mean for us? Are we always going to be watchful about what's happening so that there might be some form of intervention? So I think those are kind of big human questions about kind of how we want to live our lives. And then perhaps a much more telling example is actually what then happens if we're thinking about personalised treatment, which is an area where genomic technologies and other technologies are making real inroads in clinical management of cancer, amongst other diseases. So our research is beginning to show that welcome as many of those technologies are, they bring another set of uncertainties to play and make quite increased demands on the ways in which shared decision making actually becomes acted out in a clinical setting. So data-driven solutions don't always provide easy answers, and I think we have to be prepared for that and make sure that our expectations are not overhyped in terms of what can be achieved. And this itself brings us to the idea of new forms of responsibilities that might be part and parcel of this, that again I think we need to reflect on. To what extent are we imposing a greater degree of self-management of disease? There's been interesting work amongst sociologists of what they call the quantified self, so that we all kind of know our numbers and know various things about ourselves, that we have to kind of actively monitor our own health, as well as contribute some of those data to the data soup. So just lastly, very lastly, what would then a kind of appropriate social contract between the data world of informatics, the world of the NHS, and the world of us as people and patients, what would sustain an appropriate kind of social license or social contract that would support data-driven innovation for public benefit? I'm not going to necessarily answer that question, but I think I'm neither kind of optimistic or pessimistic, because I'm a sociologist, so I'll sit on the fence. But let's not kind of expect too much of data and data-driven innovation. And maybe it's quite good to be neither optimistic nor pessimistic, and then we find that way forward that is really responsive to societal concerns and patient needs. Thank you.
Thank you very much. I'm neither an optimist nor a pessimist. I'm a Kamart supporter. So there will be somebody else here who's a Kamart supporter, surely? No chance. Okay. Okay. And I've come here tonight from Prestwick, which, as you all know, is on the Caribbean coast of Scotland. Many of you will have been there for your holidays. You're welcome. You're welcome back. I guess Catherine described herself as young and female in the first, etc., etc. Well, I'm old male, and I'm probably beyond stale. So, but I certainly, in relation to data, I certainly stand here not as someone with a deep understanding of either the genome or the algorithm. But I do have an O-grade arithmetic, for those of you who remember O-grades. And I guess I have a shallow view of quite a lot of activity across the Scottish public sector. And my organisation, the Alliance, as the third sector strategic intermediary, will have a peripheral view of the system that others won't have. Now, it was often said of Gerald Ford, the American president, up till this point, the most unqualified president in the history of the American presidency, that he couldn't chew gum and fart at the same time. Well, I'm going to try and work my slideshow just to see if I can. Yeah, there you are. And I just wanted to preface what I'm saying with a bit of information about who the Alliance is, and that's who we are, and that's what our vision is, and it's rooted in the lived experience of individuals, and it's important just to recognise that for our purpose. We have a membership that is very, very significant nowadays, and again, just to put it in a context, realistic medicine is new on the block for us, and we've been arguing for an integrated health and social care system that values lived experience. We've argued over a decade for a system that measures and delivers better outcomes for individuals, and that's the pigeon man and the handrail man. We've researched and delivered and argued within the health and social care integration context for a system that's built on delivering personal outcomes. We've argued for a shift in the balance of care, the balance of resources, and the balance of power to individuals. We've argued for a shift, a system built on shared decision making, and my former colleague Christine Hoy is here tonight, and Christine will remember that she and I did the rounds of NHS conferences and others, talking and presenting on shared decision making 6 or 7 years ago, largely to lethargy at the time, but clearly we were lighting fires for the realistic medicine takeoff, and we're delighted to see that happening. We've argued for a system that's shaped on co-production and co-design, and we've worked with territorial bodies and others on the issue of human rights in the health and social care work plan, and in particular the Human Rights Action Plan. So that's been a very important bit of the scene setting that's been going along around this, and built on our membership. And I just wanted to list, those are 10 or 11 of the 300 organisational members. So just to give you a flavour for that, you'll see all of those organisations there, and many, many others, large and small, who have been contributing and investing members into the academic research and into health and social care systems for in some cases since the 19th century. So I just wanted to give you some feeling of the pedigree of the third sector in relation to delivering for individuals. But we in particular have stressed also and promoted person-centred approaches, and all of those organisations have done that, particularly self-management, and we run the Self-Management Fund for Scotland. We wrote the self-management strategy for Scotland at the invitation of Nicola Sturgeon, and we're very conscious that self-management of conditions is crucial in a world where people who are living with, who are diagnosed with and living with long-term conditions actually are only in contact with hospitals and GPs for a very narrow percentage of their time, and all the rest of the time they're managing their condition, they're living their condition, they're working and moving forward with their lives. But we've also promoted and stressed the importance of recovery, of self-directed support, of community-led health, of independent living, of advocacy, of personalisation, mutuality, and asset-based approaches. And I wanted to stress all of that, just really to recalibrate the arguments around health and social care, and that narrative message that I've just laid out for you is now pretty much embedded, and I see Colin Brown here, nice to see you, Colin, is now pretty much embedded in all the health and social care policy documents that exist in Scotland. The narrative, maybe not the practice, but the narrative is there. And if I focus on realistic medicine for a minute, I'll come to these points in a second. I think it challenges us with a fundamental shift in the relationship between people and professionals. It argues for and promotes a transition from a narrower medical model and a culture of, frankly, paternalistic care to a more equal, collaborative, relationship-based approach, which builds in conversations, which builds in shared decision-making, and that will have significant, moving forward, that will have significant consequences for services and cultures in the future. And we've got a programme called House of Care, which is designed to try and, they're in alliance and working with Scottish Government, which is designed to try and build on that metaphor within GP practices. And I think there will be a trend, and realistic medicine will push it towards more than medicine options. And Catherine already exemplified that earlier. There will be a drive towards more community health and well-being solutions. There will be a further embedding of self-management and social prescribing as a key elements of what will become, I hope, a locality-focused, health team organised, community-facing GP practice. And we're currently in the early stages of embedding the new GP contract. In the communities, we're in the business of building multidisciplinary teams. And in most of those communities, they'll include link workers, which is a project that we've been working on. And it will also involve new ways of working with GP clusters and communities. And realistic medicine will drive that process also. And our ethos also is that services should be created and designed with people as partners. And Catherine has heard me say this 1,000 times. When realistic medicine nicked our first strapline, you'll see our strapline is people at the centre of services. Our first strapline was people, not patients, which is a proud strapline of realistic medicine. We didn't get a licence fee for that, but I'm sure that'll come. But we believe that co-production and co-design needs to be at the centre of all of that, and empowerment is what will happen thereafter. And I just wanted to demonstrate through that series of statements there how important data innovation is when it's coupled with aligned with the experiences of people who are living with long-term conditions, people who have lived experience. And those suggestions, which I'm not going to go through, you can see them for yourself, point the way for that. I would just point out in the second bullet point there, that's a current example of where we are. We've been working with the Digital Health and Care Division in the Scottish Government to co-design a project called Our GP, supporting people right across Scotland, over 1,000 people, to develop ideas for the future of GP online services. And some GP services, GP practices already offer online booking, for example, repeat prescription orders, and this project takes that one stage further and offers citizens a partnership in the process along with GP staff. And one of our associated programmes, Alice, which is a local information system for Scotland, and programme manager Douglas Max was here. That project is a way of democratising the mapping of assets, health-giving assets throughout Scotland, and I'd encourage you to have a look at that, an open system, and we work in tandem with NHS Inform around that. I just wanted also to focus on, it's not really fair to say that people are totally aware of what data sharing takes place in the Scottish context. Very often they're not. They don't know how their information might be shared, and they don't know how it's used beyond their direct care, I would suggest. Very few people know that they have a SPARA score, for example, which indicates a likelihood of an unplanned admission to hospital-based services. But one of the user-derived key principles of self-management from our self-management strategy is I am the leading partner in the management of my health. And we believe that health literate people are increasingly expressing greater ownership of their data and seeking to access it and to download it for their own purposes. And those were comments that were derived from a sample of the population in Fife around what they thought about the use of their data. It's not a valid exercise, not reliable, but it just gives you a flavour for how ordinary people see how their data might be used. In any event, I believe we should be creative in the use of all data that relates to health and social care, because our collective challenge is to develop integrated care services based on stronger collaboration between professionals and people who use services, and better coordination of those services. And I say that wearing my Alliance hat when I'm wearing my Ayrshire and Arran non-executive director hat or my chair of an Integrated Joint Board Act. I see the challenge much more viscerally, to be honest with you, because it's much more challenging when you're putting together organisations, when you're dealing with austerity, when you're trying to reduce deficits, when you're trying to deal with demographic challenges. It's much more difficult to do that. And it's also much more difficult to remain optimistic, frankly, when you're at the sharp end. But I take an optimistic view of the world, and if you didn't do that, you wouldn't be in the game. But it is important to remember also that new technologies and data application are only tools. They don't transform by themselves the way care is provided until there's a willingness amongst all the stakeholders to embrace new ways of working. And our approach, collective approach, as we move forward into this new world, should be designed to help and not hinder that transformation. Thanks very much. Sorry, we're going to finish off with a short video, which I'm going to cue now.
Sharing information is a big part of our everyday lives. And getting the right information at the right time can be a great help, especially when it comes to our health and well-being. The way we use information about our health can help us too. For example, to support your individual care, your GP and any hospital staff or care workers who support you can securely access relevant data to help improve the care you receive. In the future, a more joined-up digital medical record should make it easier for them to quickly check and share information relating to your health and about your needs. You'll have access to your digital record online too. Increasingly, our data is helping to improve wider NHS and care services, advance health research, and find better treatments for all of us. First, some information is removed so people can't be identified. Your name and address are deleted, so the information that remains is about conditions, treatments, and the care provided. You may be able to consent to this type of information being shared for use beyond your individual care. Or, data may be collected from so many people that it's impossible to identify individuals. Using healthcare data in this way can help develop statistics, show trends, and provide other useful public health information. And in the future, you may have the option to share more information online yourself to improve the care you receive. Want to find out more and have your say? Visit the website or use the hashtag, and let's talk about data.
We do that. Let's just get a sense of whether we've got an optimistic, a pessimistic, or neither an optimistic nor a pessimistic crowd. Okay? So if you've got the use of your legs, we're going to do this for legs. If you can't use your legs, use your hand. I'd like some noise. Those of you who are optimists, stamp your feet or clap. Okay, enough. Those of you that are pessimists, do the same thing. Okay, those of you that are neither optimists nor pessimists. No, I think there was a lot. Okay, so I think, Catherine, from a data perspective, probably more optimists, followed by the mix, followed by pessimists. Would you agree? Yeah. Excellent. Good. Okay, let's start with the first question then. So, Catherine, it starts with you, but others might pick up the theme. Okay. So, he commends you on the realistic medicine, and he talks about how useful it will be in improving the effectiveness of medical practice. But he's concerned that it was designed by doctors and may overly reflect the views of doctors. And could you say a little bit more about who you've consulted with around realistic medicine to make sure you've got a totally detached view?
Okay, so yeah, it's a very good question. It's actually a question that I'm asked a lot. So we have realistic medicine, and then we think we have realistic healthcare professionals, but what about realistic people that are being looked after, and how do we engage? So I talked a little bit about the survey that we'd done. So that was Our Voice team helped us with that, which is a scientific way of asking a wide range of people across Scotland. 1,500 people are surveyed, and they come from backgrounds that are representative across Scotland, from geography, age, gender, etc. So it does mean that we think it's the best we can do with a snapshot survey. What we were hearing back from some of those figures I gave you was that people wanted the option of being listened to, of having their opinion taken into account, and very much valued that time that was going to be spent to have those discussions. So that's one way. We have a citizens' jury being developed at the moment. It's the first time a nationwide citizens' jury has been done in Scotland. We're developing the questions, and it's run like a jury in a court. So there's a panel of people who will be representative again. We will have a series of realistic medicine type questions, and then people come and give evidence. And that jury will come up with some answers, which again will give us another piece of information about what the public regard as being realistic medicine, what that would mean for them, what they want from their care. The other thing, and I should have advertised, I can't believe I sat down without advertising the next Chief Medical Officer report, which is being published next Friday, so a week on Friday. And as part of that report, we have produced, just handed to me by Helen Mackey, who's our realistic medicine clinical advisor in the front row. She's a gastroenterologist in Lanarkshire. And these are for healthcare professionals, but they have the realistic medicine logo, which is what we showed. But on the back of this, we have questions that we would like the public, our patients, to ask their doctor, their nurse, the person they're being looked after. So the questions then, and these are to be distributed to whoever would like them. Is this treatment or procedure really needed? What are the potential side effects or downsides? What would happen if I did nothing? And are there any alternatives? So we are encouraging 5 of our health boards have these questions on the walls in the outpatient clinics, encouraging people to ask, and we are supposed to say to people, have you seen these questions? Please ask. And we are evaluating, very important in a data event. What we want to know is this making a difference? Do people want to be encouraged to ask these questions? And what happens when they do ask the questions? And so I suppose I'm thinking Murray's question, maybe he'll be reassured by the fact that what we are actually wanting to do is involve everybody we look after by getting them involved more in their care at every opportunity.
Thank you very much for that, Catherine. But there was lots of nods and oohs and agreeable sounds about the questions, right? Those are the sort of questions you might wish to be able to ask. Yep. And in terms of participation, I think, Sarah, you mentioned this P4, which I thought was a nice little...
Yeah, not mine though.
No, but well referenced, but in there was participatory. So, are we really getting people to participate in this?
Okay, good question. And I mean, it is, I think what you're doing, and I think those questions are really, really important. But there will be patients who will be unable or feel unable to ask those questions, or may not wish to ask those questions either. So it requires a certain level of engagement. And so I think that, I'm not saying whether that's right or wrong, I think we need to recognise that and then work out ways to really support through patient advocacy and other methods, those that may resist engagement or may not wish to engage in the same way. So I think any forms of participation have to use very different models to reach all of the population in ways that starts from wherever they are. And the point at which you're actually coming in to see a doctor is, as we've already heard, is only one little part of anyone's experience of health. So there might be other ways of kind of really extending that participatory program, I think.
Great. And Gillian, in terms of participation, are we getting there with that? Is it a clear direction of travel for us?
Absolutely, and I think that breadth of engagement is really key. And the good thing, I think, about technology in general is that it gives you much more ability to engage a much broader set of participants, engage input and feedback, and there's much greater tool sets now to analyse that in ways that we couldn't before. Where you actually physically had to get patients or cohorts, or it doesn't really matter what field you are, you physically had to get people together, which is still really, really important. But actually new tools and techniques allows you to reach a much broader sample of whatever population that you wish to talk to, almost irrelevant of discipline.
Yeah, thanks. And Ian, that was a great video at the end there, highlighting how it might make it easier for people to understand participation.
But not nearly enough participation in truth. So Catherine was alluding to the Our Voice initiative, and which the Alliance is a delivery partner in and helped set up. And just being honest, too lightly resourced, too lightly spread across the country. And although Catherine's survey and citizens' jury is will be the best bit of it, the most reliable bit of it, and the citizens' jury, I would quibble perhaps about the the jury. You know, if it was 12 Angry Men, I would be looking for some more ordinary people on it. That's something Catherine and I might talk about. But
likely I would choose 12 angry men.
12 angry people. But Brian, you know, so it's also important to say, just in the context of real illicit medicine and community-facing activity, there is a whole tranche of strategic engagement embedded now within the integrated joint board setup. So we are obliged to report on our strategic engagement. We are obliged to demonstrate the range to which we're doing it in a way that most others aren't. And some of the initiatives that we currently have for participation in the NHS, I would suggest, are still too narrow and too limited. Public partners doesn't go far enough. Every GP practice should have a patient panel, in my view, by legislative requirement. So there is much we can do to extend the democracy of the system, but we've made good progress.
Okay, but much more to do. More to do. I think we agreed that we could come back to you and just check. How does Catherine and the other? Yes, we have. We've got a microphone. We'll just pass it along to you just now.
Thanks very much. What a wonderful set of presentations. I'm so impressed. I'm concerned to try and understand the fundamental reasons for the big problems of modern medicine. And Catherine, you have addressed the conference of preventing overdiagnosis, and you know about the campaign of too much medicine. And I think these have come about for very understandable and very well-meant reasons, that practice of medicine is a caring, compassionate occupation, and people are feeling ill and need to go for help, you know. And it seems to me that there are certain misapprehensions, certain aspects which are fundamentally misunderstood in the practice of medicine, and I would like to see the possibility of them being explored and discussed.
And does this sound like they're heading in the right direction with this?
Oh, wonderful stuff.
Yeah.
Oh, no question. It's just fundamentals I'm interested in, which I think really have to have any good expectation for the big picture, the big problems that exist to be addressed in any real manner, then one has to look at a more fundamental level.
Great, thank you very much for that. Okay, folks, other questions? You can, there we go, bing, bing. Okay, we'll come to this gentleman first and then to this lady here. So this chap here, if you could just, if it's okay with you, just introduce yourself, that would be great.
I'm the lead for the Edinburgh Association of Community Councils for Health and Social Care. I'm a patient, a biomedical scientist, member of the Alliance. I was a poster boy for Healthcare Improvement Scotland on the glaucoma referral and safe discharge, 2 pages. I don't know where it all went. I would like to bring it down to almost the community level. I agree with Ian. My work is a community. I remember the Royal College of GPs of Edinburgh had a thing called Patient Partnership in Practice. So I thought, yeah, here we go. So I trundled down to their office and met the guy. Oh, he said, we've got 5 people in Scotland, I said, who feed us information. I said, oh, really? I said, who are they? Oh, I can't tell you. I said, well, look, son, I've got 15 in my local community council. There are 41 in Edinburgh and 2,500 in Scotland. Never heard from him. That would be community engagement. And I think while data is very useful, what a lot of you people don't understand, well, some of you do, is what actually happens at the patient community level. Have you got the nurses, the OTs, the physios? Have you got the staff there to support this? You have to carry your patients with you. You have to engage with them. And the problem is, too much of this is imposed. The communities, now if you try this in Edinburgh, NHS Lothian just don't do patient engagement. I met 2 senior managers last week. We'll see what happens, but I'm not holding my breath. I was one of the original members of the South Edinburgh Public Partnership Forum. We were done away with because we took it seriously. And that, I think, is a big thing. A lot of you do not know what is going on in the community. You have to build trust in the community. And I support very much how the integration, but Edinburgh is a shambles. I don't know what's going on in Scotland. There are very good areas. You've got Dr. Sanders with the REACT team in West Lothian. There's many, but I have no way, apart from the Alliance, of finding out where good practice is. Then the problem is, how do you actually get it brought into this area where the two big organisations, the Council and the NHS, basically are not going to listen? So I can go forward, and I've done this in vision impairment. One wide praise. I was the guy that drew up the new supplementary eye examination. Don't ask me what's happened to it. And this is a problem, that you need to have this reach right into the community. And then, when there's trust in the community and they feel that their voice is going to be listened to and respected, I think Ian will understand this, then you will find flower open. At the moment, the flower is closed. Thank you.
Thank you very much for that. Okay, so Ian, I guess this reminds me of some of the work that you're doing in House of Care, mobilising local community, but also listening to the local community. And now that I see you, I recognise your picture from the front of the glaucoma.
I think for people of my who are as old as I am, and still being optimistic, I think there's a big issue about there's an under recognition of how layered public services is, even in a small country. And I said we have the Alliance have a shallow view of the whole system. And on a personal basis, I've been in local government, I've been in the enterprise network, I've been in the health and social care system, I've been in social enterprise, I've been in local government. I see a lot of that. And what happens is fantastic initiatives rise and die. And even today, and some of the initiatives that Catherine talked about that are flourishing in Tayside, for example, Tayside, who are on the cusp of eradicating Hep C, which is a fantastic initiative for people who have got Hep C, and currently that's blocked out with the other issues around Tayside. But equally, the Inspire programme in the acute care in Glasgow, in Ayrshire, the Heart programme in Ayrshire, and 1,000 other initiatives that I see across the system. But somehow or another, we can't get them scaled and transferred across. Now, I don't have the answer to that, Brian. I genuinely don't have the answer to that, other than to make our assets much more visible. But combine that with a bit of local action, and I wasn't kidding when I said I think every GP practice should have a patient panel. Some of them did for many years, and it was lost. Locality planning needs to be much firmer in the footing. I would love to see Catherine's teams in the health boards and the partnerships having realistic medicine workshops in every community in Scotland to talk about the balance between the burdens and the challenges of managing your own health and well-being, and the opportunities that flow from that. But logistically, I don't know how you do it.
Sarah.
Yes, I think those are really important points, and I think it's speaking to issues around actually what we mean by authentic engagement. And I mean, patient panels might be one such form of engagement, but we actually have to do that in a situation where those voices are heard, listened to, and that there's a feedback loop is completed, so you kind of know what happens. And I think that's not easy for many people. I mean, first of all, there needs to be somewhere for those experiences to take hold. The right questions need to be asked and discussed, and then action has to happen as a result of that. And I think we have multiple initiatives, probably lots of examples of best practice, but we don't want to create a kind of veneer of engagement that actually isn't actually getting to the sort of really nitty-gritty, the heart of the matter. And I think that requires a kind of opening up across all levels of an organisation and all levels of society to very sort of reflective and reflexive thinking, as well as being honest about where you can make a difference and where you can't. And that speaks to the wider kind of political economy of within which constrains what we're doing.
Yeah. Okay, so Catherine, Helen, you're going to be on a bus, you're going to go around the whole country, you're going to be engaging with people. But you do have plans to actually reach out with people mobilised around realistic medicine.
And some of our new thinking about realistic medicine is that some of these initiatives that you've talked about, Ian, which have come from patients, their families, their communities, is to provide those then online for people to read about and to spread them. Some of that is practice that's known locally, but it's not spread partly because people haven't thought of it, don't know. So we are changing the way that my CMO report will be. It's traditionally been a once a year paper or online document, but we're actually going to bring in some new ways of spreading what people are doing across the country, spreading good practice, spreading ideas that have grown up in communities, and allowing people, their doctors, their GPs, whoever wants that, to use those to get in touch with us. How do we start this? We've seen this, we think this is good, please help us to do it in our community.
And Gillian, the work that you're doing, I mean, it could just be another pilot here and a test here. Yeah. One of the points Ian was raising was around scale. How do you scale up and not just repeat different pilots?
It's really, really important, because pilots, if they wither and die, what was the point in the first place? And it's great about the spreading of the message. And back to a story. So Fraser, who's our project manager on the Albion Housing project I mentioned, his nan lives in Stonehaven. So the fit homes are in Inverness. His nan lives in Stonehaven. She had a fall and she was getting physio, and Fraser was up visiting her. And she said, wait till you hear about this project. It's fantastic. They're building these fit homes and they've got sensors and they're going to predict when people are falling. And he said, Nan, that's my project. So, it's absolutely about spread, and it was her physio that talked about this project that was going on that's kind of excited and enthused people. But actually, it needs to be bigger than 15 homes near Inverness. Yeah. Okay. The other aspect that I think is very difficult with the political layers and the culture. Culture is a massive part of this. And that mandate that this is great, copy it. The best ideas are plagiarised. Yeah.
Yeah, so we heard, Ian.
Brian, I was going to say though, one of the real practical issues is headroom to do that. Yeah. And there's no point avoiding this. We are in a very difficult time because we have a fantastic. I think we have got a great set of policy narratives in Scotland, but we've got health boards and IJBs that are finding it difficult to operate their way through financial challenge and demographic challenge, and so your headroom for thinking and being in the front foot is restricted in that kind of context. And I think that's where we are now.
Great. Okay, listen, we're running out of time here, but we've got this lady here.
Hello, I'm a woman of many titles, but my day job is I'm a cancer doctor. I work across 2 health boards. I think one thing that we really need to think about is health literacy, but also having an open and honest discussion about death and dying. I think we've become very technological. I spend a lot of time talking to people about genetics, results of genetic testing in terms of choosing treatment. But one thing I think we're very bad about is actually accepting that at some point we will all die, and getting people to understand that sometimes I just run out of things to do. And unfortunately, that is the way it is. And I think this is really important from a societal point of view, that we have the conversations about what's important, what's quality of life, where do people want to be, and sometimes we just can't fix it anymore.
So, very powerful point about good dying and good end of life. Sarah?
Yeah, it's a really important point, and I think that one of Catherine's questions actually relates to this. So it's actually the do nothing question. Now, there's many reasons why one might want to do nothing, and that might be the best thing in order, the disease may not progress anyway. But I think in a situation of compassionate care, we have a tendency to over-intervene. And so I think what we can use data and the evaluation of interventions in a way that prevents that constant either overdiagnosis and over-intervention. And I think you're right, and I think the kind of wider public discourse around cancer and cancer care in particular is beginning to address that very debate. So kind of switching from a kind of a war on cancer, which means you have to intervene at all costs at every stage of the disease, from, well, how can we work to prevent, to diagnose earlier, therefore improve prognosis, through to what we do at the...
And fantastic policy work in palliative care ongoing in the Scottish Government now, but also, speaking up for the third sector, loads of fantastic learning from the TCAP programme, Transform Care After Treatment programme that Macmillan runs, and a member of my organisation is involved in organising as well. So it's really important to see that. And interesting enough, from my perspective, cancer has become a long-term condition now for us. So that's the optimistic view of the situation as well.
Great. Catherine.
And Marie Curie have recently adopted the realistic medicine principles and produced an information booklet for patients to talk about just exactly what you're saying, to encourage people to have those difficult conversations, because they are difficult. And I was really pleased to be part of that. They very politely wrote to me and said, would you mind putting something about realistic medicine in it? And of course, it's exactly what we would want to do. And I'm reminded of a story. I hear a lot of stories. So a lady aged 50, 2 children, 15 and 13, diagnosed with very late, actually, with cancer in both lungs. So very immediate. What can we do? We must do everything, absolutely everything. They eventually decided that treatment in Scotland had run out for them, as it were, and they got the train to London and went to Harley Street, and they had money to do that. And I met her husband, and it was him told me the story some 6 months after she died, less than a year after she was diagnosed. And he said, we spent all that time up and down on the train to London. Some of that time my wife was on a morphine pump because it was so uncomfortable. Why didn't we stay at home with the children?
And on that note...
On that cheery note!
On that cheery note. So, no, great question. Listen, we've reached the end of our time here. There's another discussion going on just shortly. But, great. Listen, can I just ask you to give a big round of applause to your panel tonight? Thank you very much. And a big thank you to Steph in the Data Lab and all the folks here in the museum. Thank you very much indeed. Thank you.